Okay. Kish, can you hear me now?
Yeah, I can hear you, mate. I can hear you.
Perfect. Let's stop the share and get us guys on the screen. Brilliant. Okay, so evening, everyone. It is evening here in London. Let's get this back on. Welcome to Monday Night Live today, Monday, 11th of May. Time is flying by in the lockdown situation. We hope everyone is keeping safe, keeping healthy during these uncertain times. And that's the most important thing. Hope you guys are all enjoying this whole online webinar series we're doing as well. We've had over 45 different nationalities, 45 different countries registered to our webinars, which even for myself and us guys in the team was shocking. So this webinar series has gone truly international. And again, welcome to you guys tuning in from across the different states and countries. Those of you guys who are working on the front line, we salute you. Hope you guys are keeping safe, and thank you for what you guys are doing. To all my brothers and sisters fasting for Ramadan, hope the fast is going well during these times as well. This webinar series we put on was for a few reasons. Firstly, was to bring the whole dental community together, which I feel we have done, and it's gone truly international. We also want to make sure we are pushing education and free content out there. So a lot of education, and all our lecturers have kindly come on to lecture for us as well. Our top lecturers with a lot of experience behind them, who are happily sharing their knowledge and expertise as well. And lastly is to also share some positivity. It's been a few months of this negative atmosphere, all what's been going on in the world, but we were all going to get through it together, and we're sharing the smile philosophy of positivity as well. So all these webinars are being recorded. They're going to be uploaded onto our website. Big thank you to Ricardo, Marcus Blatz. We had Finlay Sutton, and we've got Pranay and Pratik, who Kish will introduce later on. And we've got next week, Janos Mako from Hungary doing morphology as well. So big thank you to all these guys, and everything will be live on our recorded onto our website. If you want to start registering for next week, it will be open at the end of today's webinar. So we've got some big news in terms of collaborations. What we've found is there's a lot of different educational academies and people doing different things. And I think at times like this, it's important to come together. So one of the educational fronts we support and work closely with is Dentinal Tubules, which a lot of you guys have heard of. And we have formed a proper partnership with Dentinal Tubules, a formal collaboration. We'll be working more together, and all our content will be going on to the Tubules website as well. So any of the Smile family, anyone on our courses, diplomas, any of our dentists, receptionists, nurses will have free access to Tubules. But not only that, if you have Tubules membership, you will get preferential rates on our diplomas, and a sign of us showing we're bringing everyone together as well. Also, what we've done, we've had a lot of undergraduates. So a lot of guys from university still studying dentistry coming on to our webinars. And what we want to do is give something back to you guys as well. So our good friends, Shivana and Zaid, we have formed a collaboration with dental training consultants, and we'll be doing a specific webinar for you guys regarding DFD, what to do, and all that as well, which I'll release later on today as well. So another formal collaboration. And now we're going to go to the main thing we're here for tonight, is Smile Aesthetics by two great people, which Kish will introduce to you now.
Thanks, Dean. Just want to echo what Jin said. During this difficult times, we are just about spreading the positivity and bringing the whole dental profession together. So by working with people like Drew over at Dental Tubules, Shivana over at DTC, it's just about bringing the whole profession together. And as working together, we'll be able to come out stronger at the end of this. So tonight, we have got two incredible speakers lined up for you guys, Dr. Pranay Sharma and his twin brother, Dr. Pratik Sharma. Myself and Jin have been extremely fortunate to have been mentored by these guys for the past number of years. And all I can say is that they have got a wealth of knowledge, experience, and incredible skills. You know, they've won multiple awards, they've published numerous papers, they're international lecturers lecturing all over the world. Pranay is a specialist prosthodontist and is also the program director over at the Eastman for removable prosthodontics. His brother Pratik is a consultant orthodontist over at the Royal London. And what is beautiful about these guys is that whilst they're at the top of their game academically and so prominent within their relevant teaching institutions, they are also in clinical practice. which means that for people like myself and Jin and you guys out there, GDPs with special interests, it makes us very relatable to them. So, you know, I've got a huge amount of respect for these guys.
So as Kish said, I mean, these two guys have been mentors to both of us and a lot of you guys out there as well. And not only that, they're two very humble dentists, two very humble educators who are happy to share their knowledge. And one thing I'm looking forward to is Pratik Sharma, who is a consultant at the Royal London, is going to release his own postgraduate diploma in orthodontics. Now, a lot of guys like myself who do numerous different orthodontic appliances, whether it be Invisalign, 6-month smile, quick straight teeth, the list goes on. The main thing a lot of GDPs, us guys, lack is the support. So I'm super excited to be working with Pratik and Gavin Mack and Michael from Matthew Cheer from the other universities to come up with this postgraduate diploma. And there'll be 3 consultants leading this. So I'm super excited. And again, some of you guys have been messaging about details about our diplomas and courses. As I've said, this is mainly for us, the profession and positivity. All that information regarding that is available on our site. So do have a look at it if you guys want. But we're not going to take too much of your time. We're going to pass you over to the guys you want to see. I mean, under 2,000 registered for tonight. We've got over 1,000 on here now. So it's a sold out event. Boys, introducing Pranay and Pratik. Let's see if we can get your mics on.
Thank you, Jin and Kish. Thank you for that very, very kind introduction. And first and foremost, I would like to start off by welcoming everyone, thanking everyone for being with us here tonight. Current stage around the world, I hope all of you are staying healthy and staying safe wherever you might be. Now, our topic for this our evening is to really talk about smile aesthetics in terms of in a multidisciplinary format. And there's no question that in our profession of dentistry, restoration of teeth and restoring function of teeth are the pivotal and fundamental components. However, there's no question that in the last few decades, aesthetics has been taking an important precedence and becoming more important and placed more emphasis on over the last couple of years. So really, the focus of our presentation for this next hour or so is really to introduce concepts relating to smile aesthetics and how we might implement those in relation to building on the fundamentals of restoration and function for the benefit of our patients. Now, we appreciate that there are lots of different people from around the world with maybe different levels of expertise, different levels of experience, and different levels of, from different backgrounds and specialties that may be tuning in this evening. But I very much hope that between Pranay and myself, we can present something this evening that all of us can take away and implement into our clinical practices. So at this point, we're just going to share the screen with you. Can I share the screen, guys?
Give me 1 second. I'm just going to make you co-host. There we go.
Okay, I'm just going to share the screen with you now.
Brilliant. Now, again, guys, those you guys have been on our previous webinars, if you have any questions, which I'm sure you guys will have, and we encourage it, put them in the Q&A at the bottom. So the Q&A is where we put all the questions. We will go through them together. We've got 2 big specialists from different specialities. So it'll be fantastic to get the insight into your questions. Are any questions in the Q&A? Is it happening, Pratik?
Yeah. Right, so as Jin introduced, I myself work as a consultant and I'm based in London in a Whitechapel.
Sorry, Pratik, have you shared your screen yet? We can't see it.
Yeah. Yeah. We've shared it.
Kish, can you see it?
I can't see it yet. It's not up. There we go.
Okay, can you see it now?
There we go. Brilliant, yeah, perfect. Good work.
Got it now?
Perfect.
Great.
So I'm a consultant based in London and I work in Whitechapel, and the hospital where I work is the Royal London Hospital, and that's a place that's seen quite some transformation over the last few years. But I've put up the slide of this historic now and building in the East End of London for a very, very specific reason. About 150 years or so ago, 2 rooms were specially made in the basement floor of this building to house arguably one of the most famous patients who's ever stayed here. Now, I say famous, but he was famous for all the wrong reasons. I am, of course, talking about Joseph Merrick, otherwise commonly known as the Elephant Man. And anyone who knows about his life will know that it was an extremely sad and tragic one. He suffered from a condition called neurofibromatosis that meant he had significant facial and body deformity. And his facial appearance and body appearance led him to be the focus of ridicule, negative social stigma, and abuse for much of the short 27 years of his life. Now, there's a strong correlation between facial attractiveness and smile aesthetics. And the reason I say that is because the two elements of the face that we most attribute in relation to facial attractiveness is first of all the eyes and secondly the smile. So it's no wonder, therefore, that patients will come to us in our relative specialties and seek enhancement to their smile aesthetics because we know it contributes to overall facial beauty. And the importance of facial attractiveness really dates back to a long, long way. Humanity for many, many years has been obsessed with facial attractiveness. And the ancient Egyptians were the first to try and describe concepts of facial beauty in proportions and try and put templates together in grid form. But the real advances in relation to facial beauty came with the work of the Greeks and the Romans. They immersed themselves and were obsessed with facial beauty and tried to produce mathematical models to depict facial proportions and symmetry that they could then implement into paintings and sculptures in a very aesthetic way. And you'll recognize some of the mathematical models and proportions that I've listed there because some of them are very, very important to us in modern day dentistry today. But what about in the modern day? Starting from childhood, from a young age, we are bombarded by images of facial beauty. Females with large lips and large eyes, and males with muscular physiques and strong chiseled jawlines, and teeth that are pearly white encompass the whole lip drape. And it doesn't stop there. Every young girl's epitome of beauty was the Barbie doll. But if you take Barbie's proportions and apply them to a normal female human being, you can see what you end up with is a very, very unrealistic and unproportioned body. And that bombardment and exposure to images of ideal faces, ideal bodies, and ideal smiles continues all the way through adulthood. And with the way we live our lives these days, with life online and this selfie culture where we're constantly looking at ourselves, it doesn't help in relation to our perception of our own facial appearance. On one hand, life online leads us to see images of perfect beauty, perfect faces, and perfect teeth. And on the other hand, taking a number of selfies and pictures of ourselves, we see ourselves in certain ways that we may not like and imperfections that we want corrected. More importantly, when you put that into the context of facial disfigurement and unsightly teeth in relation to protrusion, color, or appearance of the teeth, which is portrayed in a very, very negative way in the media, it leads to a high prevalence of appearance-related concern amongst adolescents in Western society. So it's no wonder, therefore, that patients appreciate and seek out and are conscious of the importance of a very good smile in relation to overall facial beauty and facial attractiveness. And it's really important that the modern day clinician really understands the fundamental components that contribute to the makeup of a good smile in relation to the facial perspective, the gingival perspective, and dental elements that contribute to that whole aesthetic component. So the focus of our presentation really over the next 45 minutes or so is to really break down these components into individual parts and talk about how the lip drape, the gingival scaffold, and the micro and macro aesthetics of the teeth really contribute to how we can enhance smile aesthetics for our patients. And I'm now going to pass over to Pranay, who's going to start off by talking about aesthetics from the dentofacial perspective. So if we look at the dentofacial perspective, the main elements that we need to consider are the lip framework, the smile arc, the dental midline, and the buccal corridors. So if we start with the lip framework, the lips basically envelope the intraoral tissues and the teeth. And these are muscular structures, and it's important as clinicians that we assess these both at rest and in function. General prosthodontic guidelines dictate that at rest, if you show 1.5 millimeters to 2 millimeters of the incisor ledges of the maxillary central incisors, then that's a good starting position from an aesthetic point of view. However, this is variable. So females tend to show more of their upper central incisor teeth than males, and generally as we age, we tend to show less of our upper teeth and more of our lower teeth. When the lips are in function, they produce a smile, and Tan classified the smile as low, medium, and high. And low smile lines generally describe as where you have the teeth showing, but very little papilla and soft tissues in display. The medium smile line, which is generally regarded as the most aesthetic, involves full display of the teeth, the interdental papilla, and 1 to 2 millimeters of the soft tissues. And a high smile line or a gummy smile where you have excessive gingival display, Pratik is going to talk about a little bit later on. Now, it's really important as clinicians when we're treatment planning aesthetic cases that we pay attention to the smile line, because as clinicians, this gives us some information as to potentially how challenging the clinical case may be. And I just want to highlight that with 2 cases that I'm going to show you. So this is a young patient, obviously has some disproportion, disharmony and asymmetry with their existing restorations, but also there's asymmetry in the gingival tissues between the 2 central incisor teeth. If you look at her smile line, she has a low smile line. She doesn't display the papilla and she doesn't display the soft tissues. And the asymmetry in the gingival tissues was not a major concern for her. So as long as we got the teeth correct, then she was quite happy from an aesthetic point of view. So this is a relatively straightforward case from an aesthetic point of view. We can just address the imbalance and the disharmony within the dental tissues, and actually we don't need to address the gingival tissues, and so because the smile line is low. Now compare that to this case here, which is where we have an unaesthetic maxillary central incisor tooth. But here the patient does display the gingival tissues and the interdental papilla. In order to achieve a much more harmonious result in terms of the final restoration, it's important that we address the gingival asymmetry in this case. So we require harmony here between the hard and the soft tissues, because the smile line is a bit higher and it dictates that. So what we've done in this case is just some localized crown lengthening surgery, and now we have the gingival margins which are relative to each other. Here the crown lengthening surgery has also given us one more advantage, in that it's exposed a little bit more tooth structure for us. So we have now a ferrule for our post-crown restoration, which will improve the predictability of the final restoration. So following the crown lengthening surgery, we can then prepare the tooth and place a post. And wherever we do crown lengthening, we tend to leave a provisional restoration for a period of 3 to 4 months to allow the soft tissues to settle and to mature. And following this, we can subsequently place our final restoration. Now, as a result of placing the final restoration, not only now are the teeth in harmony with each other in relation to width and length ratios and proportions, but from a gingival point of view, we have a gingival aesthetic line, something I'll talk about a little bit later on. The gingival aesthetic line is now parallel to the incisor line, which from a symmetry and a harmony point of view is much, much more favorable. If we look at the pre-op picture, we had significant asymmetry in the gal line or the gingival aesthetic line between the right and the left side, but also this was not in harmony with the incisal plane or the incisor line. So overall, a lot of asymmetry here compared to following the final restoration. So the smile line is important. You need to assess it because it dictates how difficult or challenging the case will be. I'm going to pass back over to Pratik now, who's going to talk a little bit about patients who have excessive gingival display. So Pranay's touched on the importance of assessing the smile in terms of carrying out restorations in the maxillary arch and the impact it may have on the aesthetics of that particular case. And I want to talk a little bit more about the gummy smile, and more importantly about how we may manage a gummy smile. So by a gummy smile, we really mean where there is an excessive amount of gingival display from the inferior border of the upper lip to the free gingival margin of the maxillary teeth. And before we start talking about what is excessive, you've really got to understand what is normal. And not only do you need to understand what is normal, you need to understand how that exposure of maxillary gingivae varies according to age, gender, and ethnicity over time. So in a normal patient, you should have about 2 to 4 millimeters of incisor show broadly or approximately at rest, and about 1 to 2 millimeters of gingival show on smile. However, that is subject to the degree of age variation. And what we do know is that with age, incisor show and accordingly gum show reduces with age due to an increase in the lip length and a lack of tonicity in the lip over time. So when you're planning your restorations or treatment to manage the smile, it's very, very important you take into account the age of the patient and what is the appropriate level of incisor or gum display for them, and model or target your treatment goals in coordinates with that. There also appears to be a huge amount of sexual dimorphism in relation to what is acceptable in relation to gum exposure between males and females. As a general rule, females tend to have a slightly excessive display of incisor and a slightly more excessive display of gum compared to males. And actually, they suffer from a gummy smile in a ratio of 2 to 1. So the prevalence of a gummy smile in males is about 7 to 8%, and in females, it's been reported as being as high as about 17%. But the important thing is, what impact does an excessive gingival smile, excessive gummy smile have on smile aesthetics? And it's certainly clear that excessive show of gingivae has a negative effect on smile aesthetics and overall facial aesthetics. In fact, one study has shown that 10% of patients that come to seek orthodontic treatment do so because their chief complaint is due to the excessive amount of gum they show on, in relation to their maxillary teeth. And the critical figure seems to be about exposure of about 4 millimeters. Much of the literature that's looked at aesthetics and rating of aesthetics in relation to gummy smiles tends to support that figure of 4 millimeters. And lay people tend to be less tolerant or more accepting of a greater amount of excessive display of teeth around that figure, whereas clinicians tend to be less tolerant in terms of aesthetics around that figure. But the important thing is how you manage a gummy smile should a patient come to you complaining of it. And the etiology of a gummy smile can be multifactorial. At the severe end, excessive show of gingivae at rest and smile is due to vertical maxillary excess. And by that, I mean an overdevelopment of overgrowth of maxilla in the vertical plane. And essentially, this results in moderate to severe forms of gummy smile, and you need quite invasive interventions to try and correct a gummy smile in a patient who presents with the etiological feature being VME. And we're really talking about orthognathic surgery involving a maxillary impaction, or possibly intrusion of the upper labial segment with the use of orthodontic mini implants. And I just want to highlight to you the impact that these types of treatments can have on patients who present with this type of problem. So if we have a look here, this is a patient who sought treatment because she was concerned about her gummy smile. And if you look at an intraoral frontal photograph there, you can see on only a moderate display of her teeth, there is an excessive display of gingivae surrounding those upper anterior teeth. And in fact, she was really concerned about it, as well as the malalignment of her teeth. And if you look at the patient's facial makeup in a little bit more detail, you can see it's due to the fact she's got a vertical pattern of development that's resulted in a degree of a vertical excess of the maxilla. And really, if you see a patient like this and they want that maxillary excess corrected, you're looking at quite invasive forms of treatment that involve orthognathic surgery, involving superior positioning of the maxilla in the vertical plane to try and hide the teeth and the gum underneath that upper lip drape. And with this type of intervention, you can actually produce quite aesthetic outcomes in addressing the patient's chief complaint, such as vertical maxillary excess. But in this particular case, we've got a different type of problem. The patient's got an asymmetric over-eruption of his teeth on the left side, which has resulted in a very unsightly asymmetric gingival exposure on the left side. Now, this is a little bit more challenging and difficult to deal with because there's no really surgical intervention you can actually do that will predictably just address that localized area of over-eruption of the teeth and gum on the left side. So you have to slightly think outside of the box when you're treating a case like this. And if we look at the intraoral features in a little bit more detail, you can see he presents with a pretty severe malocclusion, which has led to very, very unfavorable smile aesthetics. There's a missing lateral on the upper right side. You've got canting of the occlusal plane. Angulations of the teeth are all wrong. You've got that asymmetric over-eruption and unfavorable gingival margin and gum exposure. And you've got a very, very deep overbite that's traumatic to the lower gingivae that's resulted in significant tooth wear of the lower teeth. So this patient is one that really warrants correction, not only from health and function point of view, but also from an aesthetic point of view. And one of the major advances that have taken place in orthodontics over the last 20 to 30 years has really been the advent and introduction of temporary anchorage devices that can make a challenging case like this a lot more amenable to correction with more simplistic treatment. So you can see on the top left-hand side, just mesial to the canine, we've actually placed an orthodontic mini implant, and we're using very, very light forces to our fixed appliances to intrude that upper labial segment, with the objective being to not only level and align the teeth, but at the same time influence the dentoalveolus and improve the gummy smile. So if I move things along a little bit, you can see by the time we're coming towards the end of the pre-surgical orthodontics, we've actually got the center lines corrected the angulations of the teeth. Most importantly, we've leveled that upper arch and improved the gingival aesthetic line there and recreated space for the missing lateral incisor on the right side. And this was at debond when the patient's got a much more better occlusal setup in relation to carrying out the final restorative aspects of care. But how is this manifested in terms of his facial appearance and relative smile aesthetics in relation to the gummy smile? So if I put up his before and after photographs, you can see there's been a significant improvement in the amount of gum exposure on the left side through having that intrusion orthodontics to the upper labial segment. And we certainly know from work that's been done that the use of temporary anchorage devices
we lost him.
Sounds like it.
into the canted occlusal plane. And that canted occlusal plane really does warrant correction because it's a very, very unaesthetic feature to have in a smile. Research has shown that canted occlusal planes with an angulation of greater than 6 to 10 degrees are perceived as being very, very unaesthetic. So the fact that we use a temporary anchorage device here address two concerns at the same time to improve smile aesthetics. And while we're on the subject of temporary anchorage devices, one of the other common times a restorative dentist will ask me to carry out orthodontic treatment is in a situation like this, where they want to restore the missing teeth in the mandibular arch through implant retained prosthesis. But as a consequence of acquired loss of the lower teeth, it's resulted in over-eruption of the opposing maxillary dentition, resulting in inadequate interocclusal space to now carry out implant prosthesis rehabilitation. And this is where temporary anchorage devices, again, can be really, really useful in the posterior dentition to intrude these teeth. So you would place a temporary anchorage device in the maxillary dental alveolus, and this is placed under local anesthetic, and it's held with mechanical retention. And through our orthodontic mechanics, we can really intrude the upper buccal teeth, because our anchorage balance is now a lot more favorable, and recreate space for our restorative dentists so that they can now carry on with the restorations in the lower arch. One of the other reasons why you end up with a gummy smile is due to localized tooth wear that is at a more localized level. And again, orthodontic treatment can be really useful here to intrude the incisor teeth and then carry out restorative buildup of the teeth. Pranay showed a case earlier on where he addressed a similar problem through crown lengthening and then restoration. But equally, orthodontics can intrude the tooth up and level that gingival aesthetic line to produce a more aesthetic outcome for the patient. And this is particularly important in a patient who's got a high smile line like this patient had. So here we've just carried out orthodontic treatment, and with a first order bend, we've intruded the left central incisor to allow the gingival margins of the two central incisors to be a lot more harmonious with each other. And in so doing, it's provided space for the restoration of the incisor tooth to produce really nice harmony and symmetry, not only in the gingivae, but also in the teeth. And that allows for a more aesthetic outcome to be produced. And there are a number of other reasons why you might end up with a gummy smile, which were related to soft tissues, hypermobility of the upper lip, or conversely, a short upper lip. And there are a range of surgical and non-surgical treatments that can be used to try and address those. We don't have the time or the remit to go into those today, but there's certainly options that are available as part of as a multidisciplinary team. I'm now going to pass over back to Pranay, who's going to talk about a little bit more about the smile arc.
So moving on from the lips and some aspects related to the gingival tissues, the smile arc is also something that needs considering when you're looking at aesthetics from a dentofacial perspective. And the definition really is the relationship of the curvature of the incisal edges of the maxillary anterior teeth to the curvature of the lower lip. And ideally, you want the two to be in harmony and in balance with each other. So patients who present with a marked curvature or to the lower lip can possibly develop incisal or smile arcs which are more curved. And if the patient presents with a flatter lower lip curve, then ideally you want the incisal plane to be flatter so that the both of them are in harmony with each other. Here are two examples of cases where the smile arc really isn't in harmony. And this can occur through pathological or physiological changes such as tooth wear, as in this picture here, or through restorations that haven't been planned properly from an aesthetic point of view. You've almost got a reverse curve on the maxillary incisal plane on both of these in relation to the curvature of the lower lip. And that does not give good harmony between the two. I'm going to pass over to Pratik again now, who's just going to talk a little bit about the dental midline and the buccal corridors before we move on to the gingival perspective.
From a dentofacial perspective, a lot of emphasis is placed on the position of the midline, the maxillary midline in relation to the smile. And there is no question that the maxillary midline does contribute to being the focal point within the maxillary dentition. And where possible, the maxillary midline should be coincident with the facial midline. And the reason for this is because if the maxillary midline is positioned in the facial midline, every other tooth that's placed distal to it, whether that be restoratively or orthodontically, is placed in a sense of harmony and symmetry. And we certainly know that harmony and symmetry has a huge positive impact on the perception of smile aesthetics. So where possible, maxillary midlines should ideally be placed in the facial midline. Having said that, 70% of the population have maxillary midlines that are non-coincident with the facial midline. And in about 3/4 of the population, the maxillary and mandibular midlines fail to coincide. And when we talk about the mandibular midline, almost 2/3 of the population have a midline deviation that's off the facial midline. And it's quite reassuring for us to know that, because there seems to be a huge degree of tolerance in relation to aesthetic parameters in terms of a midline being not central. And that's particularly the case with the mandibular midline. The lack of uniformity of the lower incisor teeth and their relative small size, coupled with the fact that they're draped by the lower lip, tends to mean that you can accept a lower midline deviation a lot more readily. However, the maxillary midline position is a lot more important, and research has shown that up to about 2 millimeters of a deviation of the maxillary midline can be accepted and still be rated as fairly aesthetic. However, when those figures go up to about 3 to 4 millimeters, both lay people and professionals will judge that as largely being unacceptable and unaesthetic. But where things become really important are if you actually get a patient presenting to you whose specific chief concern is to maintain the midline. You can bet your bottom dollar if you see a patient that comes to you and actually is very focused around her maxillary centerline remaining in place in relation to a facial midline, you don't want to carry out any treatment that changes that, because they will pick it up and they will question you on it. And that was the case with this particular patient that presented to our orthodontic clinic. She had a maxillary midline that was essentially central in the arch, but she had a number of other complaints. She didn't like the spacing within her arch. She's obviously got a lateral incisor missing on the right side, and that's led to a huge amount of disharmony in the appearance of the maxillary dentition, because frequently we've got a missing lateral incisor. You have microdontia of the opposing lateral incisor, and we can see the left lateral incisor is a bit diminutive in size. So how would you go about treating and managing a case like this, knowing you've got disharmonies in the gingivae, disproportions in teeth size, tooth position, and asymmetry in the number of teeth on either side, particularly when the patient doesn't want her midline moved significantly? Now, from the point of view of managing this case, you really have two options. One is to open space and recreate space for a lateral incisor on the right side to try and produce symmetry, or the option is to close space. But the problem with both those treatments in this particular case is that it's likely to lead to a deviation in the midline. And sometimes, working with our restorative colleagues, we have to think around the box and how we might overcome a case like this and maintain the maxillary midline. So what we actually did here was recognizing the fact that this spacing on the right side and a missing lateral incisor, we treated her with a combination of restorative buildups of her teeth and orthodontic treatment to close the space on the right side, and in so doing, maintain the maxillary midline. And this was the final result she achieved. So we intruded the left lateral incisor to make the gingival margin better, which allowed the restorative dentist to build up the size of the left lateral and mask it in relation to the canine on the right side. Equally, we reduced the size of the teeth in the lower arch, which allowed the space to be closed in the upper right buccal quadrant, but most importantly, it helped us maintain the maxillary midline in the facial midline in this particular case. Buccal corridors also have a huge impact in relation to smile aesthetics from the dentofacial perspective. I'm going to spend a little bit of time just talking about the impact that buccal corridors have on perceived smile aesthetics. By buccal corridors, we mean the space created between the buccal surfaces of the posterior teeth and the commissures of the mouth when smiling. And this is a concept that was really brought about by prosthetic dentists back in the 1950s that recognized there needs to be that space there in relation to the setup of complete dentures. And it's commonly termed the negative space. From an aesthetic point of view, there's been a huge amount of discussion about buccal corridors and the impact it has on smile aesthetics, particularly because the width of a smile has become increasingly important when people talk about smile aesthetics. So we can see here in the photograph below, the width of the teeth is wider, and conversely, there's a very limited buccal corridor in this particular patient. And how we measure the width of that buccal corridor is a ratio between the width of the intercommissural distance compared to the width of the distance between the first premolars. And a ratio between those two dictates the extent to which buccal corridors exist. And by and large, in relation to smile aesthetics, the smaller the buccal corridors, the more aesthetically related the smile is. And in terms of the ratio, up to about 15% of the relationship between the width of the commissure in relation to the width of the tooth tissue is judged to be acceptable and deemed to be facially aesthetic. As that ratio deviates to 15% and greater, and particularly after 25%, buccal corridors have a negative impact on smile aesthetics. So really the take-home message is that buccal corridors ideally should be kept to a minimum. However, the situation is a little bit more complicated than just the extent of the buccal corridors. What's also important in relation to the width of the smile is actually the show of the buccal teeth and the asymmetry between the left and right sides in relation to the amount of buccal corridor present. And you can see in this photograph in front of you here, the patient shows a lot more posterior tooth tissue on the left side compared to the right side, which would make it less aesthetically pleasing. And going back to the issue of the amount of show of buccal teeth, that is also correlated with the extent of the buccal corridors, because you can have existent buccal corridors present, but if the patient shows a good amount of buccal teeth, smiles are rated a lot more aesthetic despite the presence of buccal corridors. So if you look at this photograph here, the patient's got buccally displaced canine teeth. And as a consequence of that, she's not really showing much of a posterior dentition. And she's got a very, very wide smile line. And simple treatment that widens the posterior teeth and tucks in the canine teeth, despite the fact that she's got buccal corridors present, can still lead to a significant improvement in smile aesthetics. So it's really important to consider the show of the posterior teeth in the buccal segments, as well as the extent of the actual buccal corridors. Coming back to this case, where this patient's got a number of issues that really mean he's got a very, very anesthetic smile. So one of those relates to the fact that he hardly shows any of his buccal teeth on smiling. And as you can see, he's got quite significant crossbites in his buccal segments. The other reason why he hardly shows any of his teeth is because he's got a class 3 malocclusion. And as a consequence, his maxilla is slightly retropositioned, which reduces the amount of incisor show. And more locally in relation to the upper anterior region, there are a number of factors that are really contributing to a very unaesthetic smile. Most notably, the fact that he's got an upper left central incisor missing. And the lateral incisor is approximate that upper central incisor. That's led to disharmony and symmetry in the upper labial segment, the color of the teeth, the position of the teeth, the gingival contour of the teeth. And overall, when you put all those dentofacial and more localized dental problems together, the patient really does have quite an anesthetic smile, and he wanted treatment to correct all of that. So when you see cases like this, you really need to think about managing a case like this in a multidisciplinary way. And the first element you have to do is really deconstruct the case down and focus on the various elements that have contributed to his malocclusion. So the first thing we did here was really correct the skeletal position, both in the transverse and in the anteroposterior dimensions. So the patient underwent pre-surgical orthodontics, and he underwent surgical assisted expansion of his upper arch. And in so doing, we expanded the width of the upper arch to improve the appearance of the teeth and also recreate space for the upper central incisor, which we felt was important to restore his smile aesthetics. Subsequent to that, he underwent orthognathic surgery with an advancement of his maxilla to produce a nice occlusion. And at this point, I handed it over to Pranay as the restorative dentist to rehabilitate that upper labial segment. And by the time we'd finished treatment on him, he had a significant improvement in all aspects of the features that were contributing to an anesthetic smile by addressing every single element that were contributing to it in the first place. I'm now going to pass over to Pranay, who's going to talk a little bit more about the gingival perspective and the influence that has on smile aesthetics. So if you move on from the dentofacial perspective to the gingival perspective, also known as the pink aesthetics, there's again a huge number of things that we need to think about considering. Aspects related to the quantity and the quality of the soft tissue that we may have, and the tissue biotype, whether we have a thin biotype or a thick biotype. You need to understand biology and understand the biological width and the relationship between the crest of bone, the overlying connective tissue and the epithelial tissue, and significantly where we may be thinking about placing our restorative margins. There may also be aspects related to contact points and lack of papillae. Now, we haven't got enough time to cover all of these in detail today, but I think one aspect of pink aesthetics, which does warrant some mention, is gingival shape and gingival progression. And that's something that I'll just cover with you now. So from a gingival progression point of view, if you have the gingival height of the maxillary central incisor, which is level with the canine, and the lateral incisor 0.5 to 1 millimeter apical to that gingival line, then from an aesthetic point of view, that is favorable. And that forms the basis of what we call the gal line or the gingival aesthetic line. And the definition of the gal line is basically a perpendicular line joining the gingival zeniths of the central incisor and the canine. Now, this can be classified into 4 classifications. As I've mentioned, the class 1 classification, which is generally regarded as the most aesthetic, is where we have the maxillary central incisor and the canine level with the lateral incisor 0.5 to 1 millimeter apical to that. The class 2 is where we have the lateral incisor, which is coronal to the gal line in relation to the central incisor and the canine. And here I must just give credit to Jagita, one of our postgraduate students from the Eastman. These pictures are taken from her NSE research project, which is going to be published fairly soon. So thank you, Jagita, for lending me these pictures. Class 3 gal classification is where all 3 zeniths are equal, and any other asymmetry in the gingival tissues, whether it be black triangles, gingival recession, etc., automatically by default go into a class 4 classification. So if we move now on to the dental perspective, when we look at the actual teeth and start to look at the aesthetics related to the teeth, there's 2 aspects to this: the microaesthetic elements and the macroaesthetic elements. Microaesthetic elements relate to the individual characterizations on the individual teeth, whereas macroaesthetic elements relate to groups of teeth and how those teeth relate to one another. And for the purposes of the last 10 to 15 minutes of the lecture today, I'm going to focus mainly on the macroaesthetic elements, which are highlighted. A lot of the macroaesthetic elements are highlighted in this clinical image over here. So obviously we need to get the tooth shapes and the color of the teeth correct. We need to think about the size of the teeth and their proportions in relation to each other. We need to think about the axial inclination of the teeth in relation to each other, and aspects related to the incisal embrasure. So I'm just going to work through some of these elements in a little bit more detail with you. Now, I know we've got Yanis Marco in a week, and he's going to cover tooth shape in some detail. So I'm not going to give you a detailed description of tooth shapes. What I will say, particularly for any young dentists who are with us or dentists early on in their careers, one piece of advice I would give them is to understand tooth morphology and tooth shape in order to improve aesthetics within your clinical practice. But the point I will make regarding tooth shape is that arguably tooth shape is more important than tooth color. And I just want to highlight that point by showing you these 2 crowns on the left maxillary central incisor teeth. Now, both of these crowns aren't perfect from a color matching point of view, but if you look at this image on the right of your screen, the shape of this crown
is in much more harmony with the adjacent central incisor tooth. And so as a restoration, this would probably be acceptable. Whereas if you look at the picture on the left, you can see that the shape of this maxillary left central incisor crown is significantly different to the adjacent tooth. And so this restoration sticks out at you a bit like a sore thumb and would probably be unacceptable. And this is all related to shape rather than shape. And if the aim of any aesthetic treatment that you're going to undertake requires alteration of shape in any significant way or shape or form, that it's really important that you plan this through diagnostic wax-ups, intraoral mock-ups, digital smile design, any of these diagnostic aids that we have, so that the patients and yourself can potentially visualize the final result before you start to execute the treatment. And any diagnostic wax-up needs to be assessed both from an aesthetic point of view, but also from a functional point of view. And the other important point I want to make here is once you've done all the diagnostic work, it's important, you need to understand the importance of your provisional restorations in the sequence of your treatment, and what a key role these can be in identifying and sequencing through your treatment. I'm just going to show you an example of a clinical case which shows the importance that provisional restorations can play in relation to your treatment sequencing. So this is a case here. Patient has a failing 8-unit maxillary anterior bridge, and this needs to be removed. Patient's also not happy with the aesthetics here. So the starting point of this type of case is mounted casts with a diagnostic wax-up to plan the potential aesthetic and functional changes that you may be contemplating making. But also here, what we've done is we've asked the technician to make us a shell acrylic provisional bridge, because once I take this restoration off, it's not easy to place a chair-side provisional restoration with such a long span. So all the work has been done in the planning, and we've then copied that into a provisional restoration. Once you've removed the restoration and you've placed the provisional restoration, with this provisional restoration in place, we now have achieved stabilization. The patient is comfortable and stable, but as a restorative dentist, what I can do is now I can sit back and take my time. I can assess the teeth to make sure like the vitality and the health of those teeth long-term is favorable. We can assess the restoration in terms of functions and aesthetics, evaluate what aspects we like, change or alter which aspects the patient or I don't like. We can establish soft tissue health. And more importantly, this is a really good aid for the technician moving forwards through clinical photos, through impressions and casts of the provisional restoration. We can provide as much information from the provisionals to the technician, who can then copy that into the final definitive restorations. So it's all about treatment sequencing and planning. If we move on now and just look at some aspects related to tooth size and to tooth proportion, and Sterrett's done a lot of work looking at this, and generally there's a huge amount of individual variation in size of teeth. Generally, males tend to have larger teeth than females. And if we look at general guidelines for a maxillary central incisor tooth, then the length will vary between 9 to 11 millimeters. And the width will be in the region of 8 to 8.5 millimeters. And these are useful figures to have in the back of your mind when you're planning aesthetic changes, working to make diagnostic wax-ups and looking at altering shapes of teeth. But I think what's more important than learning actual numbers is having some understanding of height to width ratios. And if we look at teeth from a ratio perspective, then generally length to width ratios of between 0.75 to 0.85 are regarded as aesthetic. If you have a ratio of length to width of below 0.6, then you'll end up with long, narrow looking teeth. And if you have a ratio above 0.85, then you'll have wide looking teeth. And if you look at these clinical pictures here, this is a lady with 2 veneers on the central incisor teeth, and you can see the ratios of width to length result in these teeth looking short and wide. And so what we've done here is just carefully address that through a wax up and the final restorations to give the appearance of slightly longer, less narrower looking teeth, so that the proportions of the teeth from length to width are more in harmony. The other important concept to bring across in this clinical picture is this concept or importance of central dominance. And what I mean by that is the central incisor teeth should be the brightest and the most dominant teeth in the arch and on display in the smile. And ideally, what you want is both central incisor teeth to be symmetrical either side of the midline, because from an aesthetic point of view, that looks much more harmonious and gives a nicer smile. Whereas if you look at these pictures, you can see asymmetry in both the central incisor teeth. If we move on to the lateral incisor, it's also useful to know the dimensions of the lateral incisor, because often we're dealing with diminutive lateral incisor teeth or peg-shaped laterals which require building up. And so general sizes of lateral incisors would be 6 to 6.5 millimeters in width and around 8 millimeters in length. And generally the lateral incisor is narrower than the central incisor by about 1.5 millimeters to 2.5 millimeters. And these figures are very useful to keep in mind when you're looking to do composite build-ups or restorations on the anterior teeth, in order to end up with a result where you've got harmony between the central incisor and the lateral incisor. Now, often the lateral incisor tooth is commonly missing. And so I'm going to pass over to Pratik now, who's going to talk about missing lateral incisors and how you plan to restore these.
As Pranay says, lateral incisor agenesis is relatively common. It's one of the most common teeth to be congenitally absent. And given the fact that it's within the aesthetic zone, patients will commonly seek treatment for this. And really, when you're working as part of a multidisciplinary team to address lateral incisor agenesis, it really brings home what Pranay's been talking about in relation to tooth size and tooth proportion. Because in order to produce an aesthetic result, you've got to make sure there's harmony in size and proportion, however way you manage that agenesis. And there are two cases that we've just put up on the screen there that have been managed in different ways. One which has involved space closure and masking the canines to mimic lateral incisors, and the other photograph where space has been reopened to prosthetically replace two lateral incisors. And you can see in both of them, a lack of careful planning has led to really quite unfavorable smile aesthetics. On the left-hand side, spacing is opened up, and on the right-hand side, not enough space has been created to favorably restore the lateral incisors, and as a consequence, they are a little bit labily positioned from the arch, as well as suffering from poor color and gingival emergence profile. So it goes without saying that when you're dealing with cases with lateral incisor agenesis and you're working to either close space and mask canines or reopen space and rehabilitate with prosthetic replacement, the communication and the coordination between the orthodontist and the prosthodontist or the restoring dentist is really, really critical to make sure that we create the right amount of space, both at the coronal level and apically, particularly in relation to implant retained prostheses, to allow for favorable rehabilitation and restoration that will allow for tooth size and tooth proportion to be implemented in the final case treatment goals. And we don't really have time to go into a lot of detail on how you would manage that as an interdisciplinary team together, but the paper that we wrote a few years ago now goes into quite some detail in answering some of those questions. So I'm just going to move on and talk a little bit more from tooth size onto proportions. And I suppose the key point to make here is that as a profession in the past, we've got a little bit obsessed with applying proportions to our wax ups and our smile design cases. And whilst there's no doubt the concept of golden proportion, divine proportion is aesthetically pleasing, I think we shouldn't get over obsessed with it in applying it to our clinical cases, because in the natural dentition, often
many will not fit into strict adherence to divine and golden proportions. And I just want to highlight that with this clinical example here. This is a before and after image of a smile makeover of the anterior sextant there. And you can see the patient pre-op had significant size and proportion issues with the existing restorations. And I've replaced those to provide restorations which are much more in harmony with the lips and the adjacent teeth. The restorations are provided don't adhere strict to the golden proportion or the divine proportion. So it's more about harmony with the lip and the facial tissues and the adjacent teeth, rather than being obsessed with a proportion or a ratio which is predefined. If we move on to look at axial inclination now, general guidance and principles related to this. Generally, the further we go away from the midline, we want to see an axial inclination which is slightly angling towards the mesial. So if you look at this picture over here, you can see from the midline, as we go more distally, the teeth actually end up having a distal inclination rather than a mesial inclination. And from an aesthetic point of view, if the long axis of the teeth tend to tilt distally, that aesthetically can have quite a negative impact. So axial inclination, and this comes very much from traditional complete denture prosthodontics, and it's been imparted into now restorative dentistry and smile makeovers. We want to go for mesially inclination the further we go away from the midline. If we look at the incisal embrasure spaces and what they are, the incisal embrasure spaces are the spaces developed between the edges of the maxillary anterior teeth, and it leads to the separation or the creation of separation between the teeth. And again, the further you go away from the midline, the wider and larger you want those incisal embrasures to be, as they give a sense of separation and also a sense of naturalism within the teeth. And I'll just highlight that with two clinical cases. If you look at the top picture here, obviously there's a huge number of aesthetic issues related to color, shape, proportions, inclination, etc. But one of the aspects here is you haven't got the separation between the teeth. And because you haven't got good incisal embrasure spaces, you don't get that natural appearance. Whereas if you look at this lower clinical picture here, this is part of a reconstruction case that I did a number of years ago. You can see the technicians built in some very nice natural incisal embrasure spaces which widen as you go further away from the midline, and it gives an element of separation between the teeth. Now, time is pressing, and I think we're just about on time, so I'm just going to pass over to Pratik, who's just going to sum up on the final two slides. So what we've tried to do over this last hour or so is really highlight to you all the various components that contribute to the development of an aesthetic smile, and more specifically in relation to how the teeth fit into the overall facial appearance in relation to the lip scaffold, the influence of the gingival scaffold and architecture around the teeth, and more specifically, the micro and macro aesthetics of the teeth. And what should really come home from all of this is when you're talking about smile aesthetics, careful assessment and treatment planning as part of as a multidisciplinary team is really critical and important. Because as many of the cases that we've highlighted through the course of this presentation, not one specialist or one specialty can address all of those concerns. And it's normally the use of an interdisciplinary team that allows smile aesthetics to be achieved for the majority of our patients. And fundamental to that is really key communication between every element member of that team, whether that be the orthodontist, the prosthodontist, the surgeon, the laboratory technician, and probably most importantly, the patient, because you've got to evaluate those treatment goals in terms of what you're achieving and what you're going to fail to achieve very clearly with the patient from the outset. And in this very harmonized, standardized, and structured way, you can actually all have a clear vision of what the desired outcome
for your patients are in relation to aesthetic and functional and health objectives. And we're going to leave you with this final slide, which really does sum up when we're talking about interdisciplinary treatment, because if you fail to prepare, you're really setting yourself up for preparing to fail. Thank you very much for listening. We'll hand back over to you guys.
Absolutely amazing, guys. Thank you so much. Even every time I see you guys lecture, I'm always picking up and learning new things. And again, echoing what these guys are saying in the chat group, a very informative and very evidence-based lecture covering both the restorative and the orthodontic side as well. So absolutely amazing, beautiful cases. I'm missing dentistry. I want to go back and see patients, and you're showing all these cases, but amazing stuff. Thank you so much. Kish.
You're welcome. You're welcome, Jin. Thanks, Kish.
Jin said, I said, look, those cases are amazing, and it just shows that your skills that you've got is just incredible. You know, we want to go back and start doing these kind of cases. And I think what you guys have touched upon there is the importance of working as a team and the multidisciplinary approach. So, you know, whenever we're in practice and you're looking at the restorative side, a lot of us just look at the restorative side and fail to often look at the orthodontic side. And working together, you can see what amazing results you guys can achieve.
Not only that, you touched on as well. I mean, we've got a lot of technicians registered on today. I think they've got their dates mixed up with Janos's and today, but a lot of the technicians, a very important thing you touched on was getting the technician and all of you on the same page as well. Because you're only as good as your technician, and you're all working together to get the best result for your patient. So again, without technicians, we would be doing nothing at all, be useless. So again, thank you to all the technicians on today as well. Boys, we've got some few questions. So I'm going to start off with the questions. And guys, if you've got any questions, put them on the Q&A. I'm going to start off one here. Where is it going? From your buddy, Joseph. So Joe's got a question. Where is it?
Hey, tell him he's not allowed to ask a question.
Joe is one of the buddies. He's a specialist endodontist. He goes specifically for Pratik. Are you aware of any literature that looks at the effect of orthodontic molar intrusion on pulp vitality?
Yeah, I mean, there's a lot of literature out there that looks at the deleterious consequences of intrusion of teeth in relation to pulp vitality, and probably more importantly, in terms of root resorption. Now, generally speaking, the types of forces that you need to cause intrusion of the teeth are relatively light. So you don't need heavy forces to cause intrusion. So as a consequence of that, intrusion of teeth doesn't lead, as long as you do it carefully and control your forces, doesn't tend to lead to loss of pulpal vitality and, or more importantly, root resorption, as long as it's done carefully. But any treatment that's carried out that puts excessive forces on the teeth can risk both of those two things happening, loss of pulpal vitality and also risk of resorption of the teeth. But as long as you do it carefully, it shouldn't be a problem. And then when I'm saying that, I'm really talking about healthy teeth. If teeth are already compromised in any way in relation to their previously traumatized or anything like that, then the ball game changes a little bit, and that needs to be fully assessed at the outset to make sure the risk of pulpal vitality doesn't happen. So you might need to be even more careful with the types of forces that you apply to the teeth to try and avoid that eventuality taking place. But it's a very good question.
Thank you for that. We've got another question here. Go for Kish.
I was going to say, we've got a question here which is quite interesting actually. Would you start with a restorative opinion, or would you start with an orthodontic opinion first? Where would you guys suggest starting off?
So I think I'll answer it, and then maybe Pranay can feed in as well, because I think it very much depends on the type of case that comes to you. And the big thing here is, what are your treatment goals? We've tried to highlight that during treatment. A lot of the time you can get away with a case which may be less than ideal in terms of smile aesthetics. And as long as you've got a patient that's willing to accept that, you might need not to expand the team to provide that ideal aesthetic result. Whereas if you've got a patient who's very aesthetically driven and wants a higher outcome in terms of aesthetics, we may need to lean on our periodontal colleagues, orthodontic colleagues, prosthodontic colleagues to bring in all the elements that we've been talking about that contribute to correct that smile. So one example of this is the example we showed where we had the vertical maxillary excess and we carried out jaw surgery to correct the patient. Now that's quite invasive treatment. If the same patient wasn't concerned about her gummy smile, we could have literally limited the treatment just to alignment orthodontics. So where you take it and who you involve very much depends on what the patient and you want out of treatment. But there are certain cases that without the input of multiple colleagues, you just won't get right. And that was the case we showed just last there, which had the orthodontic surgery, and then Pranay did the adhesive bridge in the upper labial segment. So it very much depends on the case. I don't know if Pranay wants to add anything there.
Yeah, the only thing I'd add to that is when you work as part of a multidisciplinary team, generally you need one person to lead that team and guide the team, and that's normally the restorative dentist or the prosthodontist. But, you know, and then he will work with an orthodontist, an oral surgeon, periodontist, an endodontist. But generally, it may be one person is in charge of the overall care and brings in the appropriate people to do the appropriate work. So it's a team effort, but you generally have the restorative dentist or the prosthodontist who's initially assessed the patient, worked out what's needed, what the patient wants from treatment, and then works with the appropriate specialists to achieve that. So coordinates it, if you like.
Perfect. And I just want to echo what Pratik said as well. Is like, I think that's the key element here is the communication with the patient, to understand the wish list of what the patient wants. Because as soon as you know that, then you can decide whether to expand it to the greater team or not.
Exactly.
Brilliant. Now, a question that Farhad's got here, which I was thinking the same is, do you guys use digital smile design?
To be honest, at the moment, I'm still extremely traditional, so still working off articulated casts and diagnostic wax-ups and taking that through to mock-ups and using the provisionals. I'm a big believer in using your provisional restorations to assess things before you take the step into the definitive restorations. The practices we work in central London, in Covent Garden and in Essex, we're slowly moving towards a more digital-based workflow, and that's definitely the way forward and the way things are moving. And we have slowly started incorporating the digital workflow into our daily practices. But certainly, many of the cases that we showed you in the presentation were probably done on a more traditional analog approach. But it's certainly the way forward. And my advice to all the younger guys out there would be to embrace digital technology. It is the way forward, both in implant dentistry and in general restorative dentistry.
Perfect. And I think just to echo what the guys have said as well, even myself in practice, as much as you're embracing the digital technology, you need to know the traditional theory behind it. So exactly what these guys have gone through today, I think it's important to know it, because you may do a digital smile design and something may not look right. And unless if you don't know what the theory is, all you're doing is taking pictures onto an app, whichever it may be, and just generating photographs. So I think knowing the theory is as important as well, which is good.
I think that's a very good point you make, Jim, there. And it was sort of what I was going to come on to, is the sense that dentistry, orthodontics, different specialties you look at, the digital forum has definitely embraced that and will continue to embrace it. But at the end of the day, it's a platform to deliver a certain goal, and the fundamentals and what that goal should be comes down to treatment planning. And that treatment planning decisions are based by us. It can't be done and realistically by digital platforms. If you just take orthodontics, Invisalign or Incognito, lingual appliances, they will set up with these digital, beautifully looking smiles, but it's still down to the clinician to evaluate it and check, is that right for the patient and is it delivering what I want it to deliver? So it's certainly emerging and a very, very good tool, but I think it's got to be in conjunction and doesn't replace knowledge and treatment planning and the input of the clinician in the first instance.
Well said.
We've got a question here from Drumil Shah, one of our extremely talented technicians.
Hi, Drumil.
Once you've created space for a missing tooth, how would you maintain that space while the implant integrates? A denture, would you use an Essex retainer, a resin bonded bridge? What's your go-to?
Okay, so I think that's again a very, very good question, and it's a real consideration in when we're replacing or recreating space for prosthetic teeth. And there are a couple of different factors that come in that determine what we use. Firstly, it's the age of the patient, because if you're recreating space for a lateral incisor and you're carrying out orthodontics at a young age, you can't really carry out definitive implant rehabilitation until the patient's reached skeletal adulthood. So there's this phase in between, medium term, while the patient gets to that stage that they can have implants, where that space needs to be preserved. And that can be either with a removable retainer or with an adhesive type bridge, but they have to be designed very, very carefully to make sure that those restorations don't slip the contact points. And patients have to be very compliant with wearing a retainer above that, so that that space is essentially retained for many, many years before the implant can be placed. However, if we're talking about adults, that's a different kettle of fish, because you can almost transition directly from the end of the orthodontic phase directly onto the restorative phase, given a few months in retention. So then you could just use something simple like a removable retainer, vacuum formed retainer with a prosthetic tooth in conjunction with a fixed retainer that preserves that space. And then we hand over to our restorative colleagues a few months down the line, and they can immediately carry on with the restorative aspects. When Pranay and I work together on these cases, knowing that implants take time to osseointegrate, once I've created the apical space, I actually pass the patient over to Pranay, even though the orthodontic appliances might still be on, to actually crack on and place the implants, because that's saving us time in treatment, but for that osseointegration to take place, so that when the appliances come off, we can go straight onto coronal rehabilitation over the implant.
Perfect. Thank you for that, guys. We've got a question here from Tasnim. She goes, for an adult patient who has wide buccal corridors, but a narrow maxilla and no buccal crossbites, how much can we expand the upper arch with ortho fixed appliances?
So that's actually a very, very good question. It's partly why I touched on the fact that it's not only the width that's important in relation to the extent of the buccal corridors, but also how much of the buccal show of teeth is present when the patient smiles. And Pranay also touched on the inclination of the teeth. So all these elements lead to an aesthetic show of buccal teeth. Now, if you've got a patient that's got transverse maxillary deficiency and bilateral buccal crossbites, you've got a lot of scope to carry out expansion, and the different ways that expansion can be done, either orthodontically or surgically, to try and basically produce a wider arch and a wider smile and eliminate those buccal corridors. However, in the situation that Tasnim's describing, where you've actually got quite a normal occlusion, yet you've got buccal corridors, it's much, much more difficult to widen the arches and expect that to be stable and not relapse back in. So essentially, you're limited to how much you can expand the arches if in the absence of a transverse discrepancy and in the presence of a normal occlusion. And I would say you probably, in most patients, you can't do it more than a couple of millimeters. Otherwise, it's going to result in unstable relapse of the expansion that you've carried out.
Thank you.
We've got a question from Ramit here. Your 8-unit temporary acrylic shell bridge looked amazing, Pranay. How was this achieved with regards to communicating with the lab? Did you send instructions, photos? What did you kind of send over to the lab?
So first of all, thank you for that, Ramit. And it's a really, really good question. And this is a key point to make about diagnostic wax-ups. One thing you can't do is just take upper and lower impressions, send it to the laboratory, and on your laboratory prescription, put down diagnostic wax-up. What you need to do is prescribe to the technician some information as to what changes you want from what's existing to what you potentially want to achieve. And so you need to prescribe the diagnostic wax-up to the technician. So if you're going to lengthen teeth, if you want to lengthen teeth, you prescribe to the technician, I want slightly longer teeth. If you want to change the shape of the teeth, ask for square teeth compared to triangular teeth. I mean, you're going to be basically prescribing in that prescription of the diagnostic wax-up a lot of the aspects that we spoke about in the lecture in relation to the teeth. So starting with your incisor ledge position, working how much tooth you're going to show during a smile, then looking at the midline, looking at the symmetry, looking at the axial inclination, looking at the incisal embrasures, looking at the size and width of the teeth and the proportion. All these things need to be worked out through photography, through clinical assessment of the patient, and then you prescribe those aspects into to the technician for him to build into the diagnostic wax-up. And that may get you to about 80% of where you want to be. Sometimes the diagnostic wax-up is spot on. A lot of the time you may be way off with the diagnostic wax-up. And this is where intraoral mock-ups from your diagnostic wax-up, or using a provisional restoration to trial what you've achieved in the diagnostic wax-up in the mouth, will give you further information that you can modify both from an aesthetic point of view and a functional point of view, which you then take forward into the definitive restoration. So the key message is prescribe the changes you want made to the technician in the diagnostic wax-up. Don't just ask him to guess what changes need to be done.
Yeah, great. Thanks, Pranay. I think that was one thing I just want to say as well. Is like, I know that's one of the things that you taught me was, I think my kind of lab technician dockets went from like 1 or 2 lines to like a full page worth of writing. So the more information you give your technician, the better it will be. And you support that information with photographs. And that means that your provisionals will be much more similar to your final restorations, and it's similar to what your patient will want at that stage as well.
Absolutely, absolutely. I hope that's answered this question.
That's perfect, guys. Thank you. Ria has got a question, so thanks for the question, Ria. In the case with the guy with the single central incisor, what was the temporary used for the interim till final restoration? Super interesting case.
Was that the one right at the beginning with the crown lengthening?
Yeah, I think so.
Yeah, so that was just a shell acrylic temporary, which was made from a diagnostic wax-up, and that was relined at the chair side with acrylic following the surgery.
So Ria, you are on our course. You're going to have a day with Pranay where we'll be using different types of temporary materials, from acrylics to resin-based ones, and see how the difference is as well. So we're doing a hands-on exercise later on. We've got another question here from Santosh Patil, and this is regarding temporary anchorage devices. Which ones do you prefer? And it says Chris Chang or any other. Evidence suggests up to 58% failure.
Okay, so there are 2 questions really there. One relates to what my preference is in relation to the system I use. And the second thing relates to the failure rates of temporary anchorage devices. So I started playing around with temporary anchorage devices when they really were becoming more instrumental in contemporary orthodontics. And that goes back to about 2005. So I've used a variety of different systems. And there's been huge advances in the number of systems out there that have developed, innovated, renovated, and basically got better and better over these last 15 to 20 years. The particular system I use is called Infinitas, and that's marketed by a company called DB Orthodontics. And the reason I like that system is because it's a very, very simple kit, and the implant dimensions are very straightforward to work with. They're the ones I commonly use, and they come in a very easy color-coded sort of format, so easy for me and the team to set up when we're working on our patients. So I use a system called Infinitas. Now, there's been a lot of work done on failure rates of temporary anchorage devices, and a number of studies show different amounts of failure rates in relation to the use of temporary anchorage devices. When I advise or counsel my patients about the failure rates and are consenting them for their procedure, most of the studies that have been done tend to show that about 1 in 4 microimplants will fail because they're only held in by mechanical retention. So we tend to quote the figure of about 25%. Having said that, what is very, very important in relation to the retention of a temporary anchorage device is the quality of the bone. So in the hospital where I work, we treat a lot of complex cases and are generally using temporary anchorage devices in cases where anchorage is a problem. And that tends to be hypodontia type cases. And in hypodontia type cases, the one thing we know is that you've got limited alveolus owing to the fact that teeth are missing, and not enough volume, not enough depth. And in those types of cases, the failure rates can be much, 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 much higher. So it really varies depending on the type of case you use, but most of the literature suggests about 25%, i.e. a 1 in 4 failure rate for temporary anchorage devices. It's also site dependent, but we don't really have time to go into that here.
Do you know of any courses where you can do in the UK regarding doing this stuff?
When you mean the temporary anchorage devices? Yeah, there are a number of courses. If someone wants to contact me on Instagram afterwards or answer me that question, I will let them know all the different types of courses. We actually run one ourselves, so I can give all the information. There are a number of them that are out there, but I can furnish you with all that information.
Wicked, thank you for that. Kish, anything else?
I think that's all the questions done.
We've got one more question here. You guys are twins. Have you ever switched roles dentally?
Quick answer, no. I wouldn't let Pranay anywhere near one of my orthodontic patients.
Pranay?
And I wouldn't let him place any implants in any of my patients.
Okay, that was actually my question.
We obviously work together a lot.
That was Jin's question. He's been wondering that.
I always wished I had a twin. It would have been laugh. Guys, thank you so much. There are no more questions. So what I would like to say is a big thank you to Pranay and Pratik for today. These guys and all our lecturers have come to take time out of their busy schedules. They've still got a lot of work going on with institutions where they teach, Eastman and Royal London. I appreciate, thank you guys for your input. And again, those of you who are interested in our PG diploma, drop us a message. We'll be circulating details regarding that. It's going to be a fully hands-on, run by 3 consultants, fully supported for any system using in practice and how you can apply it in. It's an 18-day course.
18 days. Yeah, and the main thing from that course is the clinical case support that you'll get for all of your cases, Invisalign, 6-month smile, QST, whichever type of fixed bracket system you want to use. So yeah, it's 18 days over a year.
And if you guys have enjoyed all our webinars, follow us on Instagram, follow us on Facebook, YouTube. We've got a channel going as well. And this has been recorded. There's a lot of information in today's fantastic presentation. So you guys can watch it again, get all the journal quotations, revisit the studies as well. And next week, we have got Janos Mako from Hungary. So he's going to be doing a live demonstration. We're going to request everyone bring a pen and paper so we can do a bit of drawing. And we're going to be doing a competition next week as well. So the best morphology picture uploaded onto one of the social media pages, which we like, will get a free place on Janos's course when he joins us later this year in the UK. So all the guys you've seen along with Janos and Pranay and Pratik are on our diplomas, and they will be coming on hands-on courses, which will keep you updated. But otherwise, guys, thank you so much for today. Appreciate it. Keep safe.
You're welcome. You're welcome. Thanks a lot.
Have a good week and keep up the positivity. Thank you, guys.
Take care.
Bye now.
Bye now.
Bless
Take
everyone.
care.
Appreciate it. Safe, everyone. Bye-bye.
Bye now.